Thank you everyone for attending. We have over 21 countries that registered and close to 100 participants that registered for the event. So thank you all for taking the time to be here. Just as an overview, we're going to do a 15-minute presentation on the paper, and then we'll open it up for a Q&A. Okay. Sorry, let me... Okay. Hi everyone, and welcome to our Sentinel GSSA Journal Club event. This event will be kicking off a series of journal article discussions that will occur over the next couple of months. Our first article will be the Lancet Global Surgery 2030 article, which discusses the evidence and solutions for achieving health, welfare, and economic development. This landmark paper was pivotal to bringing awareness to the increasing need for universal surgical, anesthetic, and obstetric services. Next slide, please. Sorry, I need to fix my screen. Okay, my name is Alicia Martin. I'm a fourth-year medical student. I go to the University of Central Florida College of Medicine in Orlando, Florida.
My name is Philip Hong. I'm a third-year medical student from the University of Florida College of Medicine.
My name is Shahyan Rehman. I'm a fourth-year medical student / on a research year at Rutgers Robert Wood Johnson Medical School. I'm also VP of Research at GSSA.
Next slide, please. So we're going to start off by introducing the key messages of inequity and impact. And after we mention a key message, we will discuss the pertinent information from the article. Next slide. So key message 1 states that 5 billion people lack access to safe, affordable surgical and anesthesia care when needed. The 4 dimensions related to this key message are timeliness, surgical capacity, safety, and affordability. Next slide. So the ideal surgical system begins with community health workers. Those health workers will connect patients in remote areas to providers, preferably primary care providers. Those providers will refer patients with surgical needs to first-level hospitals, and then afterwards will provide them with post-discharge follow-up. First-level hospitals are the ones that are intended to handle emergent and planned surgical procedures. Tertiary hospitals ideally would then be reserved for specialized care. They would serve as specialized clinical hubs, training centers, research centers, and centers for quality improvement in higher education. Next slide. So the present situation, one thing that the paper discusses is the 3 delays framework. The first delay is the delay in seeking care. This is related to financial and geographic restrictions that the patient may have, as well as poor education and cultural beliefs. Many patients in many different countries also just rely on informal providers that may not have any medical training or background. The second delay is a delay in reaching care. So there may be a scarcity of hospitals in remote areas that can actually handle surgical procedures. And then poverty is a barrier as well, especially in terms of being able to have a form of transportation to reach a hospital and or being able to afford to use public transportation. The third delay then is the delay in receiving care. And this is related to the fact that once a patient gets to the hospital, it doesn't necessarily guarantee that they'll actually get treatment. Next slide. So how do we reduce these delays? The reduction of the first and second delay is heavily dependent on community participation and having a strong pre-hospital network. Those are the community health providers, the primary care centers, and the rapid response teams. Reduction of the third delay is dependent upon actually guaranteeing that the patient will receive treatment once they get to the hospital. This requires a strong first-level hospital network. and ensuring that these first level hospitals can actually provide the basic bellwether procedures. Next slide. In addition, there is a need to meet structural and resource needs. This includes provision and management of equipment and proper training. For example, many higher income countries will provide lower middle income and low income countries with donated equipment, but they don't accompany that donated equipment with training on how to use it, any kind of long-term commitment on how, on repairing it. So this donated equipment just goes unused. Another way that this could be addressed, not that specifically, but structural and resource needs, is process standardization and through implementation of protocols and checklists. Next slide. Lastly, addressing outcomes and other opportunities. So once again, just improving first level care so that tertiary hospitals can actually act as higher education and clinical hubs. NGOs, both local and international, would ideally just assist local clinicians in meeting unmet needs and training local clinicians on how to actually meet those needs and enhancing the local infrastructure. Next slide. So at the end of each key message section, we have recommendations from the paper, both national and international. You can review these on your own because we'll be sending the PowerPoint out afterwards for your review. Next slide.
All right, for key message 2, 3, and 4, I'll be talking about those. Key message 2, 143 million additional surgical procedures are needed each year to save lives and prevent disability. Next slide. The surgical workforce, the present situation. Definition of the surgical workforce includes surgical, anesthetic, and obstetric providers, which stand for SAO. An astounding statistics is that only 12% of surgical workforce practice in Africa and Southeast Asia, where a third of the world population lives. This paper suggests that the workforce density of 20 per 100,000 should be met in each country, as you can see in the bottom right of the graph. This paper suggests that the threshold of effective outcomes of health coverage starts to decline shortly after. To better reach this suggestion, a term called task shifting has been defined as a redistribution of tasks among health workforce teams. Next slide. There has been different models provided with our focus on the task sharing between associate clinicians and general practitioners, who are not meant to replace the SAO providers, rather to complement the existing system, as the 20 per 100,000 SAO providers may not be plausible within a time frame for certain countries. To not only increase the workforce density, but also increase the quality, NGOs in high-income countries should strive for practical and effective practices that partners with local government. Next slide. This will ensure training programs within the cultural context of the local community. This partnership will also help continue to train medical education and continued professional development, which was found to increase workforce morale and retention in SAO professionals and in rural areas. Next slide. Key message 3. 33 million individuals face catastrophic health expenditure due to payment for surgery and anesthesia each year. And I'll also be combining key message 4 on the briefings. So next slide. Key message 4, investment in surgical and anesthesia services is affordable, saves lives, and promotes economic growth. Next slide. Economics and financing, the present situation. Low and middle income countries have been projected to have economic losses in productivity of $12.3 trillion due to lack of surgical care and access, which equates to an annual GDP reduction of 2%. Next slide. However, when 958 countries from 1996 to 2010 were tracked, only 2 routinely reported their expenditure on surgery. With the lack of financial provision and protection of SAO in these countries, brain drainage takes into effect. And next slide. And lastly, the way forward. Substantial surgical scale-up is needed, as well as improvement in equitable health financing mechanisms and sustainable financial provision for SAO providers are needed as well. Lastly, an increased transparency of tracking the financial flow by the government NGOs, and high-income country donations are needed to better manage the funds for the surgical development in low and middle-income countries. Next slide.
Key message 5 is surgery is an indivisible, indispensable part of healthcare. Next slide. So how do we measure our ability to meet global surgical need? Available data varies based on the level of collection, desired use, and resource availability. Data sources are broadly split into 2 categories: population-based, so you can think census or surveys, and facility-based, so assessments of individual hospitals or institutions. Each has their own advantages and disadvantages. Both are often incomplete data sets. This paper proposed the use of 6 core global surgery indicators to monitor progress towards universal health coverage in a relatively standardized way. Authors recommended that we as a global community develop national systems to collect and track this data. Next slide. So this image depicts the 6 indicators that were introduced. They're broadly split into 3 categories: preparedness, delivery, and financial impact. Indicator 1 measures 2-hour access to a facility capable of emergent and essential surgical care. 2 hours was selected because this is the rough time of onset of bleeding to death and postpartum hemorrhage if intervention is not provided. Indicator 2 measures the density of surgeons, anesthesiologists, and obstetricians, or SAO, in a population. As mentioned, less than 20 SAO per 100,000 population correlates with a substantial decrease in. Indicator 3 mentions the number of procedures performed per 100,000, and this is the most widely reported surgical indicator in low and middle income countries. Indicator 4 measures perioperative mortality. This is part of the WHO Safe Surgery Saves Lives initiative and represents the number of in-hospital deaths from any cause divided by total procedures. And indicator 5 and 6 measures to what degree individuals are impoverished or fall further into poverty or face catastrophic expenditure as a result of seeking surgical services. Catastrophic expenditure is defined as direct out-of-pocket payments of greater than 40% of household income, not including subsistence needs. Next slide. So our current understanding at the time of publishing of this paper of the health of a surgical ecosystem is often limited by the absence of local research driven by local areas of need. This is often a result of lack of funding, training, and capacity. This paper urged the global community to increase research capacity through capacity building driven partnerships. Next slide. In summary, the key messages of this paper are that the global community should work towards provision of timely, safe, and affordable care, expanding surgical procedural capacity, decreasing catastrophic health expenditure. We should recognize that investing in surgery makes economic sense when considering the lives and GDP we stand to lose if we do not act. The global community should also affirm that surgical care, inclusive anesthesia, obstetrics, and subspecialties, is an indivisible, indispensable part of healthcare and critical to universal health coverage. Next slide. So for this evening, we are fortunate to be joined by Dr. Mark Shrime for our Q&A. Dr. Shrime is O'Brien Chair of Global Surgery at the Royal College of Surgeons in Ireland and lecturer in global health and social medicine at Harvard Medical School. He previously served as the founder and director of the Center for Global Surgery Evaluation at the Mass Eye and Ear Infirmary and is research director for the program in global surgery and social change at Harvard. Dr. Shrime completed his undergraduate studies at Princeton and received his medical degree from the University of Texas. He then went on to ENT residency at the Joint Columbia-Cornell program in Manhattan. He also pursued additional training in head and neck surgical oncology and microvascular reconstructive surgery at the University of Toronto. He holds an MPH from the Harvard School of Public Health and a PhD in health policy from Harvard University. To date, he has worked and taught in Liberia, Sierra Leone, Guinea, Benin, Togo, Congo, Haiti, Saudi Arabia, Cameroon, and Madagascar. In short, we are very fortunate to have him here, and also notable when he's not working, he enjoys photography and rock climbing and has competed on seasons 8, 9, and 11 of American Ninja Warrior.
That's amazing. We're very excited to have you. I'd also like to introduce Dr. Megan Vail. She's a general surgery resident and global surgery fellow at the Baylor College of Medicine, and she will be acting as our question moderator for the Q&A portion with Dr. Shrime.
And Dr. Rachel Davis. Dr. Davis is a global surgery fellow in the Michael E. Bakley Department of Surgery at Baylor College of Medicine. She is recognized as a leader and an advocate for expanding opportunities for global involvement and education. We're so thankful to have you as well. And she'll also be moderating the questions.
Thank you all for joining us.
Great, thanks for having us.
Thanks for having us. Dr. Shrime, I definitely need to hear more about your American Ninja Warrior time.
Anytime.
So for the first question, we had a bunch of participants already submit several questions ahead of time. So I have a list of those and we'll just kind of work through them. But please, to all the participants that are on this, go ahead and insert in the Q&A or the chat box, either one we'll be watching, and we'll make sure to try to ask your questions as we go on. So Dr. Shrime, given your experience over the past 5 years, is there anything you would change about this paper?
Starting with the easy questions, huh? I think I think this paper did a lot of really good things. It took what surgeons have been working in global health since the 16th century, but it took what had been fairly disjointed, either surgeons flying in for a week and doing some stuff, or moving their entire lives to be missionary surgeons in Angola, and it sort of combined these voices and voices from surgeons who live and work locally in all these countries into kind of an academic movement with, as you all really well summarized, with data, with research behind it. So, I mean, I think this paper has done a whole lot in spurring this movement on to sort of acknowledge, to recognize that surgery isn't just something that we do on the side, but is an essential part of delivering universal health coverage. Is there anything we would have done differently? I think what I wish we had is more data. I think, I forget if it was Shahyan who was saying this at the very end. A lot of the numbers that have been, that you all reviewed are based on models. And I will tell I know right now that the papers that I published that are some of those numbers that you quoted, I know they're wrong. I don't know how they're wrong because there's no data to disprove it, but I'm asking you all, somebody disprove my papers. Because once those papers have been disproven, what that means is that we now have the data to actually show what's truly happening, and we don't have to sit, and try to model things and estimate things. So I really wish we had that. I think I'll stop there.
Thanks, Dr. Shrime. That was really insightful. So we have several questions from a bunch of different participants that ask about how obstetrics, ENT, ophthalmology, and a bunch of other subspecialties fit into global surgery. Can you speak how subspecialties play a role in global surgery?
Actually, you know what? This gets back to your first question. You know what I wish we had more of in that paper is nursing. This paper, the Lance Commission, is very heavily surgeon focused. And surgery is an ecosystem, and surgery does not work without nursing, without biomed tech. And we talk a lot about how it's an ecosystem, et cetera, but I wish we had more of that voice on the paper. The chief medical officer, or the health minister rather, of Somaliland, Dr. Edna, is a nurse, and she is one of the authors on it, but she was really kind of the only nursing voice in the room. We in high-income countries, we in the US especially, we're so hyper-specialized. Don't ask me to do an appendectomy because I don't remember how to do it. And I wouldn't expect a general surgeon to really know his or her way around a neck or in a nose. I don't necessarily think that that's good. That's an outgrowth of the fact that we've been doing, we just sort of, the way our systems are structured, we reward this sort of hyper-specialization. I think specialists obviously have a role. I am a specialist. I think specialists have a role. I also think that a push towards hyperspecialization is probably not the right thing to do. But there are movements, but in addition, there are movements. There's a global neurosurgery movement. There is a global ENT movement that is really started by Blake Alkire, because all of this burden of disease, all of this lack of access exists in every single specialty, and is probably even heightened in some of the subspecialties. You know, whereas you can get access to a general surgeon in many countries, there's literally no neurosurgeon, or there's one ENT in the entire country.
All right, thanks, Dr. Shrime. So our next question, can we talk about, I guess, some examples of recent challenges to build surgical capacity in low resource areas such as Sub-Saharan Africa? We have several registrants that are specifically interested in capacity building in Sub-Saharan Africa.
I mean, what sorts of recent challenges? I think, let me back up. Let me start by saying capacity building is such an easy phrase to say, but it encompasses a lot. When we want to build capacity, again, this goes back to what I was saying, we want to build capacity of the entire ecosystem. And let me include in that the public health researchy side of things. We tend to sort of also ignore that and say, hey, let's just deliver surgery. And in doing so, we forget, or maybe don't forget, but we kind of minimize the importance of looking at the results of what we have built. And are those results working? Are they truly impacting the patients in the way that we think they should be impacting the patients? I think the challenges, it's impossible, I think, to answer that question on a global scale, because the challenges are going to be different in every country. I think it was, I forget who, Philip, I think maybe was talking about task shifting. And I'll use that as an example. Task shifting makes a lot of sense to us as outsiders. Well, you don't have a lot of surgeons, and it takes 10 years to train a fully trained surgeon, so why don't we train a cadre of non-surgical providers to provide a limited bundle of surgical services? That makes a lot of sense. We don't really task shift in surgery here in the US. We do in anesthesia way more than we do in surgery. And questions like this are very much, they must be very locally driven. It's imperative, I think, for us not to fly in with kind of our save the world hats on and say, we know how you should fix this. And in fact, I want to bring up Dr. Edna again, the nurse, and the health minister of Somaliland. In one of the conversations back in 2014 about task shifting, she actually stood up and she said, no, I firmly against task shifting, because if you train my best nurses to become surgical providers, you're going to take away my best nurses from nursing. And so all of these cultural things that we may not even have thought about, I think it's really important for us to listen and to amplify those voices before we sort of come in with our solutions.
I love hearing stories about Edna. She's really, really awesome. If any students are interested, there's a whole thing called, like, I think it's Half the Sky. And she's like in that documentary, in that book, and she's really awesome in general. But while you're talking, Dr. Shrime, I was thinking about how Dr. Nobajit Roy, a couple of years ago at a conference, somebody was asking him some question about, like, what's the best way to do this or that. And then he was saying for high income country people to come into India, which is where he works, and then just kind of say, oh, this is how we do things where we're from. So and people, you know, automatically they want to help, and they have this feeling and this thought that, you know, I know what's best because I'm the expert where I come from. Well, actually, the expert for this place, that district hospital, is the surgeon that works in that district hospital, because he or she doesn't have the luxury of CT scans, or they know all the cultural nuances of what you can and cannot do for the patient. So I think it's very important to kind of come into whatever situation you're going into with a very humble hat. And surgical capacity, again, like you said, Dr. Shrime, such an easy word to say, but so difficult to really nail down. So that really, really is a big question. I'm just reading off the questions that the students submitted, which are all absolutely great. Yeah.
And I mean, your point is really well taken. It's so, we don't intend to be, nobody walks into global health saying, I would like to be a colonialist, but it's so easy for us to be. And there is zero reason that we should think that something that has worked in New York City is going to work in Monrovia, and or something that's worked in Monrovia is going to work in New York City. Like we live within cultural contexts and us as the experts are so not the expert when we move from New York City to Monrovia.
Absolutely. Okay, so this next question is going to be about NSOAPs. How important do you think the development of NSOAPs and LMICs is?
Yeah, so one of the recommendations from the Lancet Commission, sort of the two basic recommendations from the Lancet Commission were collect the 6 indicators and then develop these national surgical, obstetric, and anesthetic plans. This comes from the realization that, when we looked at expenditure profiles for the 900 and some expenditure profiles, only 2 countries had actually looked at surgery. So the idea was that surgery is happening in countries. It's just kind of happening over there. And there were a lot of ministers of health that couldn't say how many surgeons necessarily were in their country. I'm not even sure the Surgeon General here could tell you how many surgeons are in the US. So the idea is, if we're gonna have any change and we're gonna make surgery as an essential part of universal health coverage, then it has to come from the top. It has to come from the ministerial level. If there isn't ministerial backing, then it's not gonna work. And I think that's incredibly true. That said, I think we have focused perhaps too much on NSOAPs as the solution. Because plans are plans, right? And the important thing, this gets to what I was saying before, the important thing is, are these plans happening? And if they're happening, are they having the effect that you think they're gonna have? So I think they're incredibly important, and I think they are going, if done well, they're gonna change surgery. But into the plans, I think, have to be methods and funding for evaluation of the plans, monitoring of the effect of the plans, direct interaction with the patients themselves. Is this plan doing what it's supposed to do? Are your barriers decreasing? I think without that, they end up becoming, lovely, glossy things that end up on a shelf and nothing more.
Absolutely, Dr. Shrime. I think you're absolutely right that the NSOAPs are really great to kind of get the ministers of health to actually say that this is important, that surgery is important, but then to make sure that you continually reevaluate that. It's not just another document that they stamp or sign and take a nice picture by. It's
Exactly.
promise that you will continually reevaluate and try to keep.
Right.
Let's see, our next question here is about education. So what are the current barriers that you see in bringing global surgery education into medical institutions around the globe?
I'm going to interpret this question in one way, and then tell me if you want me to answer it in a different way. But I'm going to interpret this question as, what do I see are the barriers of bringing education around surgery in low-income countries into high-income country institutions? If you want me to answer a different question, I'm happy to also. But I think one of the barriers here, and to anybody on this call who's considering doing global surgery as a career, as a surgeon, in at least the US, we are incentivized, we are paid based on the surgeries that we do. We're surgeons, so that's what we're supposed to do. The problem is, when I'm in Monrovia, I am not generating surgical income for my department. And so what global surgery has often been is simply, well, on my free time as a practicing surgeon for 2 weeks, I'm going to fly into wherever and I'm going to, do some things. And then I'm going to come back and build my practice. And this isn't done because people necessarily think it's sufficient. It's done because that's the way that our system is set up to pay surgeons. But I think honestly, the biggest barrier that we face is the idea that global surgery is a thing you do on your vacations. It's a thing you do. Oh, it's so nice that you're interested in that, but go ahead and make sure you have a practice. So, and that push is going to come from us old fogies, but it's also going to have to come from students to say, no, look, this is a career path that I want to pursue, and I would like you to help me pursue it, as opposed to what the system is right now. And I think the other barrier, honestly, is that this field, as an academic field, is 5 years old. That paper came out in 2015. So change takes time. And as Dr. Davis is evidence of, there are now global surgery fellowships that exist that didn't exist 5 years ago. So yeah, I would encourage people on this call, on this conference, to just kind of push gently your own administrations to start considering this as a viable career path as opposed to just a hobby.
Absolutely, Dr. Shrime. And then I guess just kind of speaking to, I know we have like 21 different countries maybe signed up to participate in this. In case the question is kind of touching on a slightly different aspect on this as far as surgery, education, and other institutions. I do know that we have some great work by Dr. Bekele, where he actually became dean of a new medical school that has a completely different perspective on how to approach medicine, because it's not even thinking of task shifting, it's thinking about how when you graduate an intern, then they are suddenly responsible for doing the C-sections, for doing the laparotomies, for doing all of those bellwether procedures. So it's a very different approach to medical schooling. So that's kind of one of the other aspects of in LMICs, how they approach that educational piece.
That's a really, I mean, I think, so UGHE, the University of Global Health Equity is what you're referring to, is the university that he is now in charge of.
Yes, sir.
And I think that's a really good point. And it gets to the sort of the colonialism thing that I was saying before. The fact that this medical school, this university has completely reimagined how it even approaches this question is amazing, is spectacular. And I think, that is another thing to consider, is there's no reason, again, there's no reason that the model that we have here in high income countries has to be the model that happens in other countries. So building those universities from, as you said, the expert in that district hospital is the person in that district hospital. Building on that, I think is hugely important.
So our next question actually refers to your some of your previous work, Dr. Shrime. You had an article called "Cured into Destitution," which I thought was a really awesome title. But what more do you think can be done to find and help vulnerable populations in high-income countries, where some of our participants are from, when it comes to ensuring access to safe, affordable, and timely surgical care?
That's a great question. I'm biased because this is what my research is about, so it's a very good question. I think, right, one of the things that let me back up. Universal health coverage, according to the UN's definition of UHC, has 3 components, although in the SDGs they dropped one of them. But the 3 components originally were increased services that are offered, increase the number of people that your health system covers, and increase protection against financial risk. So increase health, increase equity, and increase financial risk protection. In the SDGs and the Sustainable Development Goals, they've only included health and financial risk, and equity has kind of moved to SDG 1, to elimination of poverty. But irrespective, for us to be truly improving health systems, we have to improve all 3 of these aspects, and financial risk is one of them. The problem that I think we have in, and I can only speak really for the US about high income countries, is that we don't realize the magnitude of financial risk that people face. Partly because, at least when I was training, I wasn't taught how much things cost. I honestly couldn't tell you how much it costs a patient to have an operation with me, partly because it costs different patients different things, and it all depends on their insurance. But we just kind of believe that because people have insurance, they're protected against financial risk. There's a paper published in 2009 by David Himmelstein, Elizabeth Warren, the one who was running for president this year, and a couple of other people, looking at bankruptcy. And they concluded that 62% of bankruptcy in the US was due to medical bills. And importantly, that 75% of people who went medically bankrupt actually had insurance at the time of their catastrophic medical expense. So insurance itself is insufficient. And this is something that I really want to caution as as countries that don't necessarily have a sort of financing mechanism yet for surgery, caution against thinking that insurance is necessarily the way to do it. Because it's not working very well here in the US. The countries that do better are the countries that have more universalized either payment or universalized delivery of care. So to answer your question, what's the best way that we can do it here? It would be to moving towards a Medicare for all type picture where everybody has at least some covered access to medical care and to surgical care. What it looks like around the edges of that can be argued, but I don't think we're going to get around financial risk in the US without at least having some universal coverage.
Thanks, Dr. Shrime. So our next question kind of looks at the future of global surgery. And of course, we're all doing this over Zoom, yes, because we're everywhere, but also because a lot of our lives have turned to Zoom and video conferencing. So what has COVID-19 informed us about global surgery that we probably didn't think about before? I'm sure we have lots of things that we can all say, but just would like to hear your opinion on that, Dr. Shrime.
My opinion is going to be unpopular, but I'm going to say it anyway. There was a push, and there still is kind of a push in the global surgery community to say, COVID-19 has proven to us that surgery is essential. But if you think about it, what was the first thing to stop at every hospital when COVID started? It was elective surgery. So to me, that those sentiments, those papers that are being published that are saying, look, we've shown how essential surgery is, kind of sound, they kind of ring hollow because of what happened. Now, that doesn't mean that we should then say, oh, well, you know, screw global surgery, we should just go back to doing vaccines and infectious disease. I think what it means is that, I think two things. One, because surgery is an ecosystem, and because part of the ecosystem is things like sterilization and things like sterile technique, there are ways to improve the health system based on things that we've learned from surgery. You know, as surgeons and people who work in surgery, we're probably among the most sensitive to sterility of anybody in the hospital. So there are things that we can do there. There are also, I think, important, especially for those of us who work in bigger hospitals, important for us to help where we are needed and not necessarily where we want to help. I've been using this image a lot, but when there's a code in a hospital, as healers, as helpers, our first reactions are often to just like run into the code because we want to help. But often the most important thing that we can do is to step back and to let the code team to get out of the way and let the code team do the thing that the code team needs to do. And I've thought about this a lot with respect to COVID-19 because as a surgeon, I was like, I want to do something. But honestly, I think sometimes the best thing that we can do is support our colleagues who are experts in ICU care, who are experts in pulmonary, and whatever the next pandemic is, you know, who support our colleagues in the best way that we can. Now, this again is to people who work in high-income countries. I think in countries where the health system is already so fragile, I mean, yeah, I honestly think it's to do as much good as we can in these situations. But yeah, I don't think it's for us to use COVID as a way to say, look at how important we are.
Absolutely, and I've definitely been in those code situations. So I guess kind of piggybacking off of what you had mentioned about the pandemic, I do kind of think that it's raised sort of a layman awareness about public health in general and epidemiology. I do think it's raised a lot of awareness to our interconnectedness as a world. Like, it was much easier to think of COVID-19 as this scary thing that was happening in China, whereas now in the US, it's obviously, we're not being allowed into countries, etc. But I think it helps us sort of mindset. So I think in that sense, it's progressive in that it helps us kind of think about global health.
You've cut off a little bit. I think you make a really good point. We are looked to, even if we're not epidemiologists, we are looked to as physicians to be sort of experts in all things health. yeah, I mean, I think it should push us to brush up on the things that we learned about epidemiology back in the day, so that we can be, again, even if it's sort of our public facing conversations with friends and family, so that we can actually deliver sort of evidence-based answers, especially in an anti-evidence world that we're living in right now.
So this next question is, again, more future focused, quite broad, but how do you see the field of global surgery changing in the next?
I'm going to point to Dr. Davis again. I think the fact that there is such a thing as global surgery fellowships now, and increasing numbers of them, is such a it's such a hopeful thing for me. That, you know, and I've said this to some of my students, I think it's incumbent on my generation to figure out how to make this a career, as opposed to just a thing that you do on the side. And those sorts of things are very hopeful to me. I think where I want to see this field change is I don't want to be the one 5 years from now making this, you know, having this webinar with you all. I want it to be the expert surgeon from the district hospital that's the one talking to you about global surgery. And there's huge pushes towards that, but that's really where I want this field to go in the next 5 years.
Okay, so let's see. And this was one of the questions submitted by Faizan on our chat here. There's a mention here of reading a couple articles regarding artificial intelligence, implications in surgery and other medical fields. Maybe this will greatly impact the care of.
Am I the only one who lost her?
No, we all lost her. Yeah,
okay.
But she was just asking about the implications of artificial intelligence in how it may impact global surgery.
Yeah, that's a really good question, Faizan. AI is obviously a very sort of very popular thing to be talking about right now, and holds a lot of promise for medicine in general, and I think for surgery. The issue with AI, right, is that to develop really good artificial intelligence models, you have to have a lot of data. The reason that Google can you know, look at a picture and tell you that it's a cat in the picture and not an airplane is because Google's algorithm has gone through, you know, millions of pictures of cats and millions of pictures of airplanes. We don't have those sorts of data in global surgery yet. We barely have those sorts of data, honestly, in surgery in the US. Now, I know COSEXA, the College of Surgeons of East and Central and Southern Africa, have gathered a lot of operative data, something like 200,000 cases over the last few years. So we're starting to get some of these data, but I think that's going to be the key to creating artificial intelligence models that allow us to predict outcomes or predict procedures that are needed or predict ways to overcome someone's financial barriers. So I think broadly, yes, huge potential impacts. Currently, the barrier to AI having huge potential impacts is a lack of data.
Great. Can everybody still hear me?
We can hear you, but it's just lagging a little bit.
Okay, I might just turn it over to Rachel.
I can step in and ask a couple of questions about data reporting. So I think one of the really helpful things about the Lancet Commission was having some metrics that we were all sort of following as a team, saying these are the things we want to prioritize and getting everyone on the same page for reporting those. And we're supposed to be doing it biennially, but is that something that you feel like is happening? How are we doing in terms of data collection and keeping track of where we are right now in accomplishing our goals?
Rachel, that's a very good question. The short answer is no, we're not doing it biennially. What's happening is that many of the models that were built are being updated biennially based on other data that have come in. These models were built based on publicly available data, and that does get updated. The surgical data has been harder to come by, partly because there isn't a convening force to make that data collection happen, right? The WHO doesn't have any power to say to ministries of health, you have to collect this. Many of the global indicators are collected either by ministries because they want to, or by other organizations, the DHS, for example. So all this is to say, yeah, we're lagging, but there's hope. It's not all negative. So the DHS, the Demographic and Health Survey, which I forget how many countries DHS is in, but in a lot of countries, they do household surveys every 5 years. So they go out into the community. They're not just hospital-based, they're out into the communities, and they do surveys of countries, nationally representative surveys of countries every 5 years. Just this year, the DHS included a surgery module. It's a few questions, it's not a lot, but it's the first time surgery has been included in the DHS. And I want to say it was 2 weeks ago, Zambia published the creation of that module and their own rollout of the module in their DHS. That is, I think, huge. Now, with these modules, the DHS has a kind of required core module, and then it's got optional modules that countries can say, yes, I would like to look at this. And surgery is right now an optional module. But still, the fact that it exists and the fact that countries can actually pick it and say, I'd like this to be part of our 2021 DHS survey, I think that's going to really sort of increase data collection.
How do you think that the involvement of countries in international organizations like the WHO impacts their willingness to participate? And how do you think, I mean, you're going to be Irish now, but how do you think this is going to impact the US to be sort of moving back from its involvement in the WHO?
I mean, the WHO, the UN, all of these multilateral organizations are built on an ethos of collaboration. So a really important ethos. And it's an ethos that so to get to NSOPs, National Surgical Plans that we talked about before, one of the reasons that there's been such momentum on national surgical plans, if any of you all have read Malcolm Gladwell's book, The Tipping Point, is that basically a few countries started deciding that they wanted to do national surgical plans, and it just got to the point where it sort of hit a tipping point, and now a lot of countries in Sub-Saharan Africa, in the Pacific, are building their national surgical plans. And that happened, I think, Rachel, because people were in these multilateral organizations talking about it. Zambia stands up and says, we are the first to have a national surgical plan. Rwanda's like, well, I want one. And I think that's super important, this cross-national sharing of ideas. We as the US have decided that we know better, so we're gonna leave that. I think it's super clear to everyone that this is going to be damaging both to the WHO and, because the US does contribute a whole lot of money to the WHO. I believe proudly that Ireland decided to step up their contribution something like 4 times more in response to that. So it's gonna be hurtful for the WHO, and I think that's the reason that our president has decided to do it. But it's gonna be hurtful for us as well. It's gonna be hurtful for Americans to not be part of these conversations and not be around, and be able to, for better or for worse, be able to influence some of these conversations. Yeah. So I don't know of a single public health person that thinks that this withdrawal is a good move.
I do want to just give you a question from one of our participants online who's asking about the difficulty for foreign medical graduates coming to the US or other high-income countries to get residency training. Do you think that that in some way contributes to perpetuating difficulties with surgical care in LMICs?
Honestly, it's a really good question. I think there may be a little bit of an assumption underneath that question, which is that the only good surgical training can happen in high-income countries. And I think that's not true. Again, to get to Megan's point, I really love this point, which why I keep coming back to it. The expert in the district hospital is the surgeon working in the district hospital. For a colleague of mine, I have a good friend and colleague that works in Togo. If he were to come to the US and learn how to do robotic transoral resections of cancers, it's great. And he could do he's a very good surgeon. He could do really well. But so what? Like, what have we trained him to do? He's going to go back to his hospital in Togo where there isn't a robot, and a robot is $1 million or $2 million. There's never going to be a robot, not in his career time. So I don't necessarily, I get the impulse of where this question is coming from, but I don't think the answer to to discrepancies in surgical care in low-income countries is everybody must be trained in high-income countries. I think the answer is cross-national collaborations and is, as we talked about before, capacity building within countries, as opposed to thinking that only the best happens in France or the US.
Yeah, thank you. And we only have 4 minutes left, so we're going to conclude with a closing question from all the students about how students can get involved in global surgery, and if you have any recommendations for them in general for pursuing a career in global surgery or academic global surgery.
Yeah, here's what I will say, and here's what I say to a lot of people, which is also unpopular. As a medical student and as a resident and as a fellow, your job is to be the best medical student and resident and fellow that you can be. It's not necessarily to be the best global surgery student, it's to be the best student. And I think the reason for that is because global surgery has this reputation of, oh, it's just these people who want to fly away and not do their jobs. It's imperative for us to be the best and to show that this isn't, we're not doing global surgery because we're lazy or we want to escape. We're doing global surgery because it's a passion of ours. And we are the best students. We are the best residents. We are the best fellows. And also, we want to be global surgeons as a career. So I think that's number one. And that gets into sort of number two. As a resident, you're not going to have a lot of time to do global surgery. As a student, you don't have a ton of time to do global surgery. Do things like this, like be a part of GSSA, be a part of Incision, and don't lose the fire. But also, if you're going to go out and be a surgeon in Angola, you want to make sure that you're a good surgeon when you get there. You don't want Angola to sort of get the scraps of training. You want Angola to get the best surgeons that they can get.
Thank you so much, Dr. Shrime. That was really enlightening, and we're so grateful to have had you for the Q&A tonight. So thank you for that.
Yeah, thanks for having me, and thanks for everyone for all the questions that you submitted.
Yes, thank you. And thank you, Dr. Davis and Dr. Vu. We really appreciate you moderating and providing your insight. And thank you to all of our participants. You guys are really what keep this thing going, and we're really grateful for you all.